Anatomy and physiology of the voice are fascinating and of great importance to our interdisciplinary fields. Basically, they mean what the voice is and how it works. I have no conflicts of interest relevant to this presentation. The human voice is extraordinary. In a moment, it can convey the terror of a scream or the beauty of a song. Yet, surprisingly, we have only begun to learn what constitutes the voice and how it works. The voice is not limited to the region between the hyoid bone or tongue bone and the suprasternal notch or top of the chest. Virtually all body systems are involved in voice production. If you look at a singer performing, this is obvious. That, by the way, is Bruce Springsteen, for those of you in the room over 60. Singers understand this, speech-language pathologists understand it. Physicians don't always understand it until they study more about the voice than we get routinely in medical school and residency. The larynx is the portion of the anatomy that receives our greatest attention, yet it is not even necessary for voice production. Laryngectomy patients converse perfectly understandably. It is necessary, however, for normal or superior voice production. This component of the system consists of a skeleton, mucosa, intrinsic and extrinsic muscles, each of which can be the source of a voice problem. And part of our job as clinicians, and among clinicians I include not only physicians and speech-language pathologists, but also voice teachers, and of course, that means singing, acting, and other. We need to diagnose all this. And the more we understand about the components of the parts, the more we can understand what we're actually trying to accomplish with the imagery that we often use, and become more articulate at diagnosing and fixing medically or fixing in the studio. The laryngeal skeleton consists of the thyroid, cricoid, and arytenoid cartilages, and other structures that have names but are less important. There are only a few things that you need to remember to learn anatomy if this is new material for you. If you remember thyroid, cricoid, and arytenoid, you have most of it. The thyroid cartilage is located in the neck when we are born at a level of around the third cervical vertebra. This is the thyroid cartilage, which is horseshoe-shaped, the hyoid bone, which attaches to tongue and to larynx, and below the thyroid cartilage, you'll see the cricoid cartilage, which is the only circumferential structure in the airway. The rest of them are open in the back. And the arytenoid cartilage is perched atop the cricoid cartilage. Although, when we are born, the laryngeal structures are around C3, they drop to C6 or C7. That lengthening of the vocal tract is part of what we hear as voice maturation. In addition, please note that behind the laryngeal structures, you see the spinal column with a little bit of intervening soft tissue. When we are born, the cartilages are cartilage. As we age, they ossify and become bone-like. The structures behind the larynx are pretty unforgiving. So if you get struck in the neck, for example on a steering wheel or by a fist, and drive the larynx posteriorly, when we're young and it's cartilaginous, it compresses. As we get older, such as I am, it's bone-like and it's brittle and it fractures. That also matters to the surgeons in the room. One of the procedures for transgender surgery is cricothyroid approximation, as described by Carano, or fusion, as I described, in which you bring the cricoid and thyroid cartilages closer together, and in the procedure I like, slip the cricoid cartilage behind the thyroid cartilage. In a young person with a soft cartilaginous larynx, that works well. In somebody at 50 or 60, it doesn't work so well. So these anatomic specifics are useful for a lot of things in all of our fields. If you look at the larynx from the outside, anteriorly, you see in the male the thyroid prominence, or Adam's apple. If you slice the larynx down the middle and look at the inside, you see the thyroid cartilage. There's no thyroid cartilage in the back because, remember, it's horseshoe shaped. The cricoid cartilage, front and back, it's circumferential. The arytenoid cartilage, and this white structure that is mislabeled vocal cord. First of all, we stopped using the term vocal cord in favor of vocal fold decades ago. And second of all, this structure is neither. Nevertheless, if you remember it, it will be helpful as a reference point for what's to follow. The laryngeal cartilages are attached by joints that are not screw-like. They have pliability and flexibility. The cricoarytenoid joint and the cricothyroid joint move in multiple planes, and that complex motion is important for normal voicing and extremely difficult for us to recreate if it has been injured. If you look at the larynx from the front, as you see in this image on the right of your screen, from the top you see the hyoid bone with the epiglottis peeking out above it, the thyroid cartilage and the cricoid cartilage. The cartilages are connected by membranes. Remember, I promised you if you remembered a few cartilages, you could deduce the rest of the anatomy. Anatomists are not particularly imaginative. So this is the cricothyroid membrane, and this is the thyrohyoid membrane. Picture in your mind's eye where the vocal folds and the arytenoids are. Use your X-ray vision. As we remove the thyrohyoid membrane, we see the leaf-shaped epiglottis, which is designed to fold down and protect our airways so our Valpolicella doesn't end up in our lungs. And we see still the cricothyroid membrane intact. As we remove that, this space is artificially widened a little bit. But as we remove that membrane, we can see inside the signet ring-shaped cricoid cartilage rising behind, and the pyramidal-shaped arytenoid cartilages seated atop the cricoid cartilage on a curved surface. The details of that anatomy have been described. We're not going to cover them today, but I do want to mention to you the anatomy of the cricoid cartilage, which is, as I told you, circumferential and fixed, and an area that is prone to stenosis from trauma. If you look at the size of the airway, this is frontal plane diameter, the narrow end of the range is almost 9 millimeters in females and about 11 millimeters in males. And if you look at the endotracheal tubes that anesthesiologists push down our airways when we undergo surgery, again, a reminder, female is almost 9, a little less than millimeters on the narrow end. A 7.0 tube is bigger than that. Anesthesiologists like to use the largest tube possible, an 8, sometimes a 9. And 8 is large enough to have to be forced through that narrow area with males who are at the lower end of the diameter range. A 9 is much bigger. These tubes also can traumatize the vocal folds and the posterior area of the larynx, but in the area that causes stenosis, Most of what is used routinely is bigger than we would like it to be. So if you undergo surgery, there are a lot of reasons why you should request the smallest tube possible. The image on the left shows you the larynx. The top is anterior or front. The bottom is posterior or back, and right and left. You see the hyoid bone. Below it you see the epiglottis, the thyroid cartilage, the arytenoid cartilages, and arising from the vocal process of the arytenoid cartilages, this white band, which is the structure you saw before, mislabeled vocal cord. It extends from the vocal processes of the arytenoid cartilages to the inside portion of the thyroid cartilage, just below the origin of the epiglottis. Some of you may remember from embryology that the vocal process of the arytenoid cartilage is of an embryologic different origin from the rest of the arytenoid cartilage. So there is an embryologic fusion plane where the vocal process emanates from the body of the arytenoid cartilage. That is why in the operating room we never put anything below the vocal process and lift. If we have an anterior dislocation, there are other techniques described for reducing it. This area is a fracture waiting to happen and difficult to repair. On the right, you see the motion of the arytenoid cartilage in the cricoarytenoid joint is complex. There are old descriptions of it, but it's actually more complex than our traditional understanding. I mentioned to you that the arytenoids are perched atop a curved structure. This is the arytenoid, this is the cricoid. These little spaces are the cricoarytenoid joints. They look a lot like little temporomandibular joints or little knee joints. They are synovial joints, just as our other joints are. This is in adduction, with the vocal folds brought together. On the right, you see the arytenoids in abduction, and they don't just move out. They move out and down the curve of the cricoid cartilage and sit in an entirely different attitude. This is very complex motion and nearly impossible to restore historically. This shows roughly the differences during phonation and during respiration, but you'll see them better here. This is a CT scan created by Jean Abibal and Albert Castro in a living human. This is the arytenoid sitting atop the cricoid cartilage. Notice how small the contact area is in that curved elliptoid cricoarytenoid joint. Play the right one, please. This is the contact area. When you look at how small that is, it's amazing that these joints don't get dislocated more often than they do. A very delicate structure, more delicate than a lot of medical students first learning how to place an endotracheal tube. The larynx utilizes intrinsic and extrinsic laryngeal muscles. The intrinsic muscles alter the position, shape, and tension of the vocal folds. They're responsible for adduction, bringing the vocal folds together, abduction, bringing them apart so that we can breathe, and longitudinal tension. The recurrent nerve innervates most of those muscles. If you add to your short memory list superior laryngeal nerve cricothyroid, which is the tensing muscle which lets you hit high notes. If you can remember superior laryngeal nerve cricothyroid when you're doing your multiple choice test at the end of the lecture, everything else is recurrent laryngeal nerve. Just so you know, none of that is strictly true. There is intermixing that has been discovered more recently, but for practical purposes, it's close enough. The primary muscle that lets you take a nice breath, pulls your vocal folds apart, is the posterior cricoarytenoid muscle, or PCA. The other intrinsic muscles are, for the most part, adductors. Again, anatomists not being creative make this very easy. The posterior cricoarytenoid originates from the posterior aspect of the cricoid cartilage, inserts into the muscular process of the arytenoid, and when a muscle fires, contracts, it shortens. So as it shortens, it pulls the muscular process of the arytenoid out and up. But more happens than that. The muscles that do this are innervated by complex, tiny nerves that we try not to injure when doing thyroid surgery. And just to inspire you a little bit, the gross anatomy of these nerves was not discovered until the 21st century. When I started writing, I think, the 3rd edition of my professional voice book, I wanted to update the anatomy chapter and went to look up the branches, the terminal branches of the recurrent laryngeal nerve, and they had never been described. So there is still good research to do in all areas, even gross anatomy. When the intrinsic muscles fire, they do more than just move the vocal fold. The posterior cricoarytenoid that we just looked at to breathe, I showed you pulls the arytenoid vocal process out and up, and you can see the dotted line is neutral position. The solid line shows you that the edge is raised and pulled out. The cricothyroid, I told you, increases tension, so as you increase tension, what would you expect? The vocal fold thins and sharpens. The thyroarytenoid medial belly, or vocalis muscle, is parallel to that structure mislabeled vocal cord. When you fire that, what moves? Nothing. It's isometric. So that muscle bulks up and forms the body of the vocal fold, which provides lateral resistance when our vocal folds contact each other. Without that, if that were weak on one vocal fold, when the other vocal fold hit it, it would flutter out of the way, and that's exactly what happens with vocal fold paralysis, whether it's from having a nerve cut or from having botulinum toxin injected. The thyroarytenoid muscle has 2 bellies. The one in which we're most interested most of the time is the medial belly, also called the vocalis muscle, the body that we just discussed. The lateral cricoarytenoid muscle brings the vocal processes together in the midline. For the physicians in the audience, if you put a laryngeal EMG needle in the lateral cricoarytenoid, the LCA muscle, you will hear a rapid firing and then it settles down. If you have your needle in the thyroarytenoid muscle, the vocalis muscle, which is what we usually try to inject for spasmodic dysphonia, you get a steady discharge. That's how you know which muscle you're in. Why would you care? First of all, when you're doing a spasmodic dysphonia patient, you want to be in the right muscle. Second, one of the reasons people get recurrent granulomas are inflammatory masses that commonly happen in the region of the vocal process, although not always. They're aggravated by trauma, they are aggravated by reflux. But for the physicians, if you do a frame-by-frame analysis of closure patterns in the people who have already had 2 or 3 or 4 surgeries for granuloma, you often will find a lateral cricoarytenoid dominant closure pattern rather than working in concert with the inner arytenoid, which we'll come to. So the vocal processes strike first, and then you get medial compression. That creates excessive trauma. It's as if you had a choice of having your foot stepped on by me or your foot stepped on by Katie at 100 pounds in a high-heeled shoe. You would pick me, because if you concentrated her weight over a half-inch heel, it would hurt more. That's the mechanism for some of those recurrent granulomas, and you can treat those by putting botulinum toxin in the lateral cricoarytenoid muscle, and then having the voice therapy team work with the people so they can maintain that muscle balance pattern after the Botox were resolved. The inner arytenoid muscle is the only one of this group that has bilateral innervation, and it works to close the posterior glottic chink. It provides medial compression. It brings the cartilaginous portion of the larynx together. The cricothyroid muscle brings the cricoid and the thyroid closer together. As that happens, the arytenoid rocks back further away and the vocal fold gets stretched, and that's how we increase or decrease pitch. Now, I mentioned to you that the cartilage attachments, the joints, are flexible. They're pliable. They're not screw-like joints. That means as you squish the larynx together or stretch it apart, you change the angles of the joints and the resting conditions of the muscles suspended among them. The extrinsic laryngeal muscles are responsible for vertical laryngeal position, and they're the ones that a classical Western trained singer uses to keep the larynx at a fairly constant position throughout pitch range, usually a little bit below neutral. They're the ones that push the larynx down in the untrained singer when you sing low notes, and have it right up in the untrained singer singing high notes. Those are muscles in the neck, the ones that stand out on your average weightlifter or mediocre Helton tenor. Oh, some of you are still awake. How nice. The strap muscles, some, attach to the laryngeal cartilages, and they elevate or lower the larynx. The balance of doing that is quite important, especially to the professional singer. If you cut a muscle, this is the thyroid cartilage in the center of this image below the laryngeal cartilages. If you cut a muscle like the sternocleidomastoid muscle or the sternothyroid muscle, in order to be able to get access and do a thyroidectomy, even when you sew the muscles back together, which some surgeons do and some surgeons don't, when they scar, they shorten. So we advocate, whenever possible, not to cut strap muscles, although it's done routinely by some surgeons. Not necessary. Makes the surgeon work a little harder to not do it, but usually it can be avoided. May only be shortened 1/8 of an inch. Doesn't seem like it should make much difference, does it? What do you think would happen if you put an 1/8 of an inch lift in one shoe of a marathoner? By the 15th mile, that asymmetry would cause hip pain, knee pain. Altering the ergonomics of this system can have substantial clinical effect. So the best way to treat that is to avoid it by doing the surgery right in the first place. The anatomy inside the larynx includes, among other things, the true and false vocal folds, the ventricles, and the mucosa. On the left of screen, you see the larynx split down the center again as it was in the early drawing. To the left is anterior or front. To the right is posterior. You see the true vocal folds. Above them, the false vocal folds, and a little pouch in between that is the laryngeal ventricle, or ventricle of Morgagni. On the right, you see the same anatomy, but sectioned in a frontal plane. Please note several important things. First, these red structures are the vocalis muscles, or medial bellies of the thyroarytenoid. Above them are the ventricles and the false vocal folds. Below them is the airway, the trachea. Please note that the trachea meets the region of the vocal folds in a steeple-shaped convergence. That anatomy is very important to the aerodynamics of the voice system. If it is altered surgically, for example, by squaring the bottom part of the vocal fold so that it's no longer convergent, it causes changes in ease and ability of phonation. If it's done a little bit, it might actually be helpful. If it's done too much, it definitely isn't. Also note that the vocal folds are three-dimensional structures. They look more like the size of two fingers than they do like two pieces of paper. Many of you are used to looking at pictures of the vocal folds from the top down. You get a false sense of two dimensions. They are three dimensions. They come together over a large area. Many people consider the false vocal folds unimportant, many people meaning surgeons. They are important for several reasons. First of all of us have seen people who have had substantial vocal fold trauma and those vocal folds don't work, who can phonate pretty well with false vocal fold phonation. Often it's pathologic, but not always. I have a patient who is a professional voiceover artist in New York who phonates only with her false vocal folds. So they can be useful. Second of all, as you all remember from physics, I'll try not to use that word too often. In an aerodynamic system, you have flow of whatever, in this case air, but it could be a fluid, that passes through a narrowing and generates vortices, little swirls. The aerodynamic system is controlled in substantial part by the downstream resistor. And the laryngeal inlet and false vocal folds are important components of that system. So you can't just go in and cut them off to be able to see the vocal folds better and expect no consequences in a high-performance voice user. When we are born, the musculomembranous portion of the vocal folds and the cartilaginous portion of the vocal folds have about a 50-50 relationship. On the right, you see a photograph of a live human larynx. Up is anterior. The white structures are the true vocal folds. The fullnesses above them are the false vocal folds. The bumps in the back are the regions of the arytenoid cartilages. In the adult, we're about 3/5 musculomembranous and about 2/5 cartilaginous in our vocal fold proportions. It has been taught previously that the musculomembranous portion is phonatory, responsible for making sound, and the cartilaginous portion is respiratory. We know for sure that in patients who have webs that completely remove the musculomembranous portions from the system, patients can generate good sound using the mucosa over the cartilaginous portion as oscillators. So for sure they work in pathologic circumstances to our advantage. We don't really know, unless Dr. Sundberg has something new to tell us. We don't really know how important cartilaginous portion vibration is in high-performance voice users, but I would suggest that until we know more, that the entire vocal fold mucosa, including the cartilaginous portion, should be treated with respect. We know that it functions as an oscillator under some circumstances. It may function as an oscillator more than we recognize so far. So we can't just go in and take a laser and cook off a granuloma or a lesion in the back just because it's in the cartilaginous portion, as opposed to the striking zone or middle of the musculomembranous portion. The mucosa of the larynx is dramatically more complex and fascinating than mucosa elsewhere, such as on the inside of the cheek. We have a lubricated contact surface which has serous and mucinous glands. Serous glands make thin liquid, mucinous glands make thick liquid, and we balance them. That's how we get the oil on our vocal folds to be of the right viscosity. That allows the vocal folds to come together and pull apart efficiently without surface cell damage. Many of the things that we think of as dehydrating, like antihistamines, don't actually necessarily dry us out. They shift from a serous to a mucinous predominance. It's like thickening the oil in your car engine, and it doesn't work right So when we hydrate, one of the things we are doing is shifting back to a more appropriate viscosity. Throughout the respiratory tract, we have pseudostratified ciliated columnar epithelium that has little hair cells, except on the contact edge of the vocal folds. If you've ever seen photomicrographs of cilia, or better, videos of cilia, you'll know they're little hair cells that move. If you put them on the edges of the vocal fold and smashed them together 100 times a second if you were male and 200 times a second if you're female, those hair cells wouldn't last very long. So the mucosa over the edges of the vocal folds is stratified squamous epithelium without the cilia, specialized to tolerate the contact and trauma of phonation. The epithelium contains a basement membrane and layered structures with superficial, intermediate, and deep lamina propria and underlying muscle. Minoru Hirano in Kurume, Japan, described in 1975, it was published in English in 77, the layered structure of the vocal fold. This slide is one of his. This is a vocal fold cut as if you were facing forward. So this is a left vocal fold, the right vocal fold would be over here where the Drexel logo is, and the space in between is the glottis. The glottis is a space. Everything in this system is referred to with relation to the glottis. Everything is glottic, subglottic, meaning below the vocal folds, supraglottic, meaning above the vocal folds. There is no glottis. It doesn't exist. When your vocal folds come together and make contact, it's not there. Yet, it's our primary referent. Unlike the buccal surface inside of your mouth, this mucosa has a an epithelial, squamous epithelium surface, superficial, intermediate, and deep lamina propria, and vocalis muscle. The epithelium and the superficial layer of lamina propria, also known as Reinke space, form the cover layer. They move, they make the mucosal wave. The intermediate and deep layers of lamina propria are a transition layer to the body which provides lateral resistance. The intermediate and deep layers together are called the vocal ligament, and they are that white structure that was mislabeled vocal cord. They are the vocal ligament which attaches through the macula flava to the vocal process and to the thyroid cartilage inside near the middle. And the vocal fold is built around them. They also differ in structure. Fibroblasts and other structures that make scar are scarce in the epithelium and superficial layer, but there are plenty of them in the vocal ligament and muscle. So what have you just learned? You've learned anatomy in layers. You've learned physiology. The cover layer makes the mucosal wave in layers. You've learned healing in layers. So we designed both diagnosis and especially surgery in layers. This is why modern, precise, delicate microsurgery with instruments that look like ear instruments was evolved, so that if we have lesions that involve only the epithelium and superficial layer, as nodules and most cysts and other structures do, we now have surgical techniques that allow removal of those lesions involving only the involved tissue without traumatizing the subjacent layers and provoking scar proliferation which obliterates this elegant structure and which we are not very good about repairing. So it's not just anatomy, it's the keystone of everything that we do. How many of you lie awake at night wondering how the epithelium is connected with the superficial lamina propria? Well, it turns out there's a basement membrane. Just like basement membranes elsewhere in the body, And it is subject to the same basement membrane pathologies and basement membrane diseases. If you have dermolysis bullosa et dystrophica, which is a basement membrane disease where the skin detaches, if it involves this area, the epithelium can fly off, but for the most part, it doesn't because of this structure. This structure has type 3 collagen loops that emanate from and reinsert into the basement membrane, through which pass type 3 collagen fibers, and those linkages keep the epithelium attached to the lower layers of the vocal fold. This region also contains the other proteins and other structures that are involved primarily in wound healing in this area. These linkages and those protein distributions vary from person to person and are undoubtedly controlled genetically. So, how many speech pathologists? Okay. Think about this for an application of this. You have a child who comes into your office with vocal fold nodules. The kid screams, the mother screams, the aunt screams. You say, no wonder the kid has nodules. Everybody in the family screams, and you put the whole family into therapy. This is Philadelphia. We have more than 500,000 Italians in South Philadelphia. If you stand in the middle of South Philly in the summertime with the windows open, you can hear all the dinner conversations for 6 blocks in any direction. How come only one kid got nodules? It's not that simple. There's a genetic predilection, and there is a pretty good chance that what we're looking for is in this region of the vocal folds, and we have a whole lot more to learn about it. And of course, that predilection affects not only likelihood of nodules, but likelihood of failing to heal from other routine vocal fold trauma, and likelihood of scarring and healing badly following vocal fold surgery. Before Steve Gray died at an unreasonably young age, defined as anybody younger than I am now, he and I were working on a project to try and see whether we could define that genetic characteristic group and screen for it, possibly by something as simple as a brushing preoperatively. The notion was, and I've thought about this ever since these genetics were described at all, wouldn't it be nice to be able to do a genetic analysis preoperatively and say you don't have a 1 to 2% chance of getting a bad scar, you have a 25% chance or a 50% chance because of an identifiable gene. I believe it's there. I have no evidence to prove that, but I suspect that eventually we're going to be able to find it and that it will be very useful in surgical decision making. The vocal folds form the oscillator of the vocal tract. They make a sound. That sound can't be made unless the power source sets the oscillator into vibration, any more than a trumpet mouthpiece does anything until you blow into it. The sound is fairly boring, but it passes through our supraglottic vocal tract. Power source, oscillator, resonator system. So how does all of this work? All of the components work in concert. And it's a complex system, and it starts in the brain, even in tenors. It starts in the brain.
Oh my God.
Neurolaryngology is perhaps our newest subspecialty. Think about anything in basic phonation. You think about what you're going to say or sing. You preset all of the anatomic structures based on your auditory memory of the target. You utter a sound, you hear the sound, and instantaneously, in milliseconds, adjust it to target. And if you're deprived of auditory input because you're in the middle of a choir, for example, Singers have learned to do this tactily, singing by feel rather than by ear. Sort of an amazingly complex operation that we take for granted and do all the time. And it doesn't go awry nearly as often as it should, given its anatomic and physiologic complexity. We could talk for a long time about fascinating areas, the periaqueductal gray matter, where respiration, emotion, and phonation have pathways that converge, about some fractal, chaotic things that happen in spasmodic dysphonia patients. This is an area that I commend to your additional study, but you will hear more about it from other lectures. Breathing is a combination of active and passive forces. We inhale actively. Those of you who are sitting out there then relax and exhale passively through recoil of your chest and related structures. I, however, am up here pontificating, so I am expiring actively with force to project my voice. And that's what we do as we sing professionally, and why respiration is such a critical component of any analysis of what's working or what's not working with the voice. We support phonation using large body muscles. We inspire using the diaphragm, which is a curved muscle, and when it fires, it flattens out and creates a vacuum and sucks in air. And the external intercostal muscles between the ribs. And we expire by using abdominal muscles and back muscles and the internal intercostal muscles, and tightening the abdomen and back so that we compress, squish together our gut contents. They get pushed up against the diaphragm. What does that do? Well, think about a balloon. You have a balloon full of air. You want to squeeze air out of it. You bring your hands together on the side of it and squish it together. What are you doing? It's physics again. Sorry. You have gas in a container. You make the container smaller. You increase the pressure in the gas, and it's forced out. So as you force gut contents up into the thoracic area, you decrease the size of the airspace and increase the pressure of the air. And ideally, with a vector of force in an upward direction, push it up between the vocal folds. That generates this subglottal pressure that makes the vocal folds come apart. Let's look at vocal folds held together by an arbitrary amount of force, and we'll just also arbitrarily start with them closed. You bring your vocal folds together with an elective amount of adductory force. You then generate subglottal pressure. When the subglottal pressure exceeds the adductory force, you push the vocal folds apart. As soon as that happens, air flows because of the elasticity of the system and because of the Bernoulli effect of the airflow, the same effect that pulls a shower curtain into your shower. The vocal folds begin to close. Please note that the vocal folds open from the bottom up and from the back forward in this three-dimensional vibratory margin. As they close, they also close from the bottom up. This is called a vertical phase difference. So the motion of the vibratory margin of the vocal fold itself is a lot more complex than just opening and closing. Not hard to imagine how a mass or even a collection of fluid ballooning out the vocal fold alters that motion, changes sound, changes phonatory efficiency. This harks back to Dr. Sundberg's brilliance. The glottal source signal is fairly boring. Once it passes through our system of infinitely variable interconnected resonators, rather than having a fairly boring sound, it sounds a lot like a trumpet mouthpiece without the trumpet attached if you cut people's heads off just above the larynx. You know, we try to do that only with selected attorneys and administrators. Instead of having that boring drop-off, we have what looks like a beautiful mountain range. Each of the peaks in that mountain range is called a formant. The formants are responsible for a lot of things. They're responsible for vowel intelligibility. They're responsible for helping the resonator, helping to create our individual vocal personality. And a special one, the singer's formant, there's also a speaker's formant, is responsible for audibility. It's this formant, fifth formant, that allows you to go to a Phillies game, or a wedding, or some other loud event, a bar, and talk for a long period of time, be heard, and not become hoarse. It's not the only thing, but it's one of the important factors, and we take it into account. That singer's formant is known in the singing world as ring. Pavarotti did not have a particularly large voice, but if you were a little late and were stuck out in the lobby, you could hear him through the doors. You could hear him over 120 professional choristers. It wasn't because he was loud, it was because of his ring. Interestingly, the fifth formant is responsible for some other things as well. It's centered in different areas, in different Fox. We think of it as around we think of it as around 3,000 hertz, but it's closer to 2,400 in basses and a little higher in sopranos. Tenors is in the 2,800 to 3,000 hertz range. Singer's formant does something else. One of my favorite demonstrations from Dr. Sundberg when we were still at Juilliard was with a voice synthesizer, and the only thing he did was change the center frequency of the singer's formant, and you could hear the voice change from soprano to bass just with moving the singer's formant. So again, important, and more to this than most of us appreciate from the basic knowledge. So how do we put all this together? Why do we care about this as clinicians and teachers? Let's look at how we control a couple of things, starting with fundamental frequency. There are two ways to control fundamental frequency. One of them is with flow, and another is with tension. Now, you know you can do this with flow. When you turn a water spigot on and then make it go faster, or a hose, what do you hear? So the pitch goes up as flow goes up. Not efficient in the human voice. It interferes with the mechanism we use to control loudness, amplitude. So mostly we use our cricothyroid muscle and superior laryngeal nerve and stretch the vocal folds and change the mechanical properties. How about intensity? How do we control that? Suppose you go to a great lecture and you want to applaud at the end. You do this and applaud with your hands close together? No. You bring your hands apart. With your vocal folds, you do the same thing. You increase adductory force, hold the vocal folds together, generate lots of subglottal pressure, blow the vocal folds far apart, increase the amplitude of displacement from the midline. Then you've increased Bernoulli force, you've got lots of elastic force, the vocal folds snap together, suddenly cut off the airflow, and that's the basic mechanism that you use to get louder. Why do we care clinically? Well, we can measure all of this stuff, too. And we do, routinely, every day in the voice lab. Flow glottography gives us a notion of how the voice is being used with relation to adductory forces and subglottal pressure. Breathy voice, you all understand. Pressed voice is the sound of a baritone announcing to the world that he is indeed a baritone. Flow phonation, which I hope I have been using for most of today's discussion, is an optimal balance between subglottal force and adductory pressure. Why does it matter? It matters because it impacts the sound level at the glottic source. The difference between pressed phonation and flow phonation, as Dr. Sundberg showed, can be up to 15 decibels. Is that a lot? Well, remember that decibels add logarithmically, not arithmetically. So if you go into a paper plant and it has a machine putting out 90 dBA, actually putting out 90 dB, let's say, sound pressure level, and you turn on a second one that also puts out 90 dB, what do you have? It's not 180, it's 93. If you turn on two more, you now have 4 machines, you're looking for earmuffs. You have 96. How many machines do you have to turn on to get a 15 decibel increase? 32. Now, if you remember that most of our patients get into trouble and see us trying to be heard, then you can guide your treatment and teaching strategies to address these efficiencies. If we optimize intensity at the glottal source and optimize the fifth formant, we allow people to be heard without having to work hard compensating using muscles in the neck that are not designed for power function. And of course, using the support system, the large power muscles, for power. Now we can measure all this. We can and do measure voice spectrum and look at the voice formants. We measure various acoustic parameters. We look at vibration. You'll see plenty of stroboscopy later. And we look at innervation with laryngeal electromyography. And all of that is what comes together to make the modern voice clinician. It allows us to figure out what broke first, because by the time we see people, usually everything's not working right. What probably caused the voice injury, and how we fix it. So what all of these technological, anatomical, and physiologic insights give us is another vocabulary. It doesn't replace the art of medicine. It doesn't replace the art of teaching singing. It augments. I still teach. I still use the same bel canto imagery that I was trained with, but I know what it means and what it's supposed to do, and if it doesn't do it right away, I change to a different strategy because I understand not the image, but the purpose of the imagery. The same is true in the medical office. The same is true in the speech pathology office. The more we know, the faster we are to detect success or absence of success, and the better equipped we are to introduce different strategies to accomplish the goal, because we're focused on the pathology and the desired outcome, and not on the method. Thank you for your attention.